Welcome to Revolutionizing Healthcare, where we discuss the latest in AI and machine learning for healthcare. Today, in our first ever specialty spotlight session, we will dive into the field of oncology. And before we welcome our outstanding panel, I would just like to briefly introduce the people running these sessions. So first, the brains behind the session is Mihaela van der Schaar, who is the John Humphrey Plummer Professor of Machine Learning, AI, and Medicine at Cambridge University. I would also like to introduce you to Tim Oosterlink, who's a medical student at KU Leuven in Belgium, affiliated with the Van der Schaar Lab.
And you just heard Tim Schubert, the other Tim, a medical student at Heidelberg University in Germany and affiliated with the Van der Schaar as well. Today, we have four outstanding panelists for you today. We have Professor Dr. Olivier Memento. He is director of the England Institute for Precision Medicine, professor of physiology and computational genomics, and also associate director of the Institute for Computational Medicine. And next, we have Professor Sileni Han from KU Leuven University in Belgium, and she is professor of gynecology and oncology. Next, from the University of Oslo, we have a very wide array of panelists today from all over the world. We have Professor Oldenburg. He is professor of oncology at the University of Oslo. And next, we have Dr. David Crosby, head of prevention and early detection research from Cancer Research UK.
This session will consist of two main parts. And the main part of the session will be a panel discussion. In this part, we will ask each panelist to briefly share their clinical or research focus, and then we will ask them to provide the most important unsolved challenge they see in oncology, where AI or machine learning may be helpful. You can also ask questions throughout the session in the chat, or even share your own challenge for machine learning in healthcare. And we will address as many of your challenges and questions as possible towards the later half of this session.
Yes, and to make sure we don't run out of time and allow everybody to share their opinion, I will sometimes pop a small timer in my window, and that tells you to wrap up your question, and it's time to move on to the next thought. We will start off with Professor Jan Oldenburg. The University of Oslo sets a benchmark for oncology and medical education. Could you summarize your research focus in 2 to 3 minutes? And could you share the challenge you have for the machine learning world? Thank you.
Thank you. Thanks for the invitation again. I think it's an outstanding panel. I might take the role of a simple oncologist. I don't have that big profile. I have 50% of my working time dedicated to research, and I can, just to give you my background, I work within uro-oncology, that is bladder cancer, it's prostate cancer, kidney cancer, and testicular cancer. And I think possibly it's best to focus here on prostate cancer because it's the most common. And I can give you two fields I'm working on, which might be sometimes hard to unify. The one is I'm active in clinical practice guidelines from the ESMO and the AAU, the European Association of Urology. And I'm not sure how much you know about evidence-based medicine. That is the way we try to work. So mostly we assess large phase 3 trials and look how big is the benefit, which would be the efficacy. And that is often very different from the effectiveness. Effectiveness is what you would get of treatment effect in the more general population. Randomized trials are usually highly selected. And even though these protocols are written to select the the athletes of cancer patients, and they get the most modern treatment, it is often very difficult to see what is the recommendation for all. And sometimes the trials, despite very similar selection criteria, result in different results. The other thing I'm working on is prostate cancer database, and to my mind, it could in the future it could be a near perfect database, because we have in Norway we have these unique person identification numbers, and this allowed to match laboratory results, pathology results, income, even education, the received treatment, the prescribed drugs, everything could potentially be in that database. I'm not sure that I will get that through, but that would be my ideal scenario. And I asked myself, how will it be possible to give general treatment recommendations based on an algorithm which has access to a nearly perfect database? It's not only all the PSA values and the age and the comorbidities, but it might as well be the radiologic raw data, and it might be histopathology. There's much more probably to detect for an AI than for the human eye who's looking at the screen for a CT or MRI, or at the through a microscope. So that would be my challenge number one. How do you think that will be possible to have highly granular data, get a recommendation by a machine-based learning algorithm telling you this patient should be treated like that, and very similar to my eyes probably, would get a very different recommendation. How do I explain it to the patients, and how will that end up in the guidelines? Or are these two fields which are really not possible to unify?
Professor van der Schaar, would you, as the machine learner in the room, have your view on how you would tackle this?
I guess try to respond to Jan's challenge. So Jan, first, it's great to hear that you are also working on prostate cancer. I've been very fortunate here at the University of Cambridge to work with the professor of urology, Vincent Gnanapragasam, on some aspects of prostate cancer. But I'll start first to talk about what you mentioned, and you mentioned many challenges. One of them is creating a data set and a database that contains this very diverse information. I think machine learning potentially can serve not as the smart thing in the room, but maybe even the dumb machine learning model that can help harmonize the data, clean the data, identify potential errors in the data. So one unsung song of machine learning is its power in improving the quality of the data, going beyond just dealing with missingness, but identifying errors, outliers, and potentially harmonizing data sets across Norway, and why not across Europe, or potentially more generally the world. So I think that on the data side, I think that that's exciting. Another thing that comes to my mind the moment you talk about such diverse data, because you are very fortunate to have such rich data sets in Norway, which is more difficult to achieve in another country, there is an opportunity using machine learning to identify what is the minimum amount of data that we need for a particular patient at a particular moment in time to indeed inform prognosis or inform the effect of different types of interventions. So I think what's nice about it is trying really to identify what information we patients often worry about, what may add to our risk. And conversely, the clinician may not have all the information in front of them to make the right judgment, potentially to decide between treatment 1, 2, or 3. So I think one thing that machine learning can do is also define and focus the mind of the clinician and potentially of the guidelines to understand what pieces of information are most relevant and yet easy to acquire. A good example comes from a collaboration I have had recently in lung cancer, where it appears that by just looking at very few variables, we can make all sorts of predictions about the chance of these patients to indeed have lung cancer. This may be more difficult for patients that have already been diagnosed with prostate cancer, and one may need to identify not only their prognosis, but also what are the unique predictive and prognostic variables, some that will tell something about prognosis, some that will tell about the effect of different types of medication. So I think that this is where machine learning can hopefully further support the decision-making of the clinician. In terms of guideline, I would like to turn the question back to you and maybe to the panel, because I think that machine learning can help speed up the evolution of guidelines. I'm paraphrasing another clinical collaborator from UCLA who once told me, well, guidelines are often created by a small minority of clinicians on the basis of not always best evidence. And then everybody is trying to deal with these guidelines, even though they don't fit the patients we have in front of us. I don't know whether this is true, but potentially one solution could be that guidelines could be, so machine learning could look at best practices and how different clinicians practice and why they make different decisions for seemingly similar patients. Extract what seems to be both average as well as personalized best practice, and provide these guidelines for inspection and examination of clinicians to potentially refine guidance or improve guidance or evolve guidance as new medications or new information appears. So I think that they could be used as a companion in the guideline creation, as well as in the decision support for the patient in front of the clinician, which may relate or may be an outlier.
Mm-hmm. Thank you, Professor van der Schaar. And the reason that she had so many answers and to talk about the challenges is, of course, because oncology is so multifaceted. The possibilities are endless. And secondly, I would like to go to Professor Elemento. Would you be able to tell us a bit about yourself in about 3 minutes and share the medical challenge you have for the machine learning world?
Absolutely. Well, first of all, thanks for having me today. I'm excited to participate. I direct the Englander Institute for Precision Medicine at Weill Cornell Medicine, the medical school of Cornell University in the US. We broadly use genomics and AI to make medicine more personalized. Our vision of medicine is very different from the medicine we have, right now at this moment. We envision the future of medicine as being very personalized, where we will analyze every single patient with multiple technologies to get a tremendous amount of details about their disease, not the average disease that thousands of people may have, but their disease and what's special and unique about that disease. And then we want to use this detailed maps of a disease to be able to tailor therapy to identify the most likely effective therapies, combination of drugs, combination of behavioral modification, lifestyle adjustments, drugs, treatments, and to essentially be able to treat every patient based on their disease, and again not based on everybody else's disease. So we approach this in different ways, in multiple different directions, which I think I can summarize as 3 different directions. One is we do whole genome sequencing of patients, germline and somatic, and we work a lot on cancer patients. So for the sake of simplicity, I'm going to focus on cancer, and I think that's also the focus of this discussion. But for cancer patients at Weill Cornell, we do whole genome sequencing, meaning that we sequence the DNA of the tumor cells from beginning to end. We want to analyze every single mutation that we find in those genomes, and we want to really integrate all this information to kind of provide the best treatment recommendations. Now, we know that's not enough, right? Because if you were to look at a cancer, a typical tumor, you would see that most tumors consist of tumor cells, but in fact, there's also a lot of non-tumor cells within the tumors. And so we're also using technologies to get a snapshot of tissue at single cell resolution, where we can essentially analyze the battlefield of cancer, where we can see the cancer cells and the surrounding cells that they interact with that are not typically cancer cells, like immune cells or blood vessels and so on. And we think that this is the interaction between the tumor cells and those other cells that really is going to dictate how tumor cells respond to chemotherapies or targeted therapies and so on. And we have pretty good evidence that's the case. So the third direction is a more functional approach to precision medicine. It's realizing that the two technologies and directions that I mentioned are very static, right? We get snapshots, of disease and obviously can collect a lot of information, but it's very static. One thing that we'd love to be able to do is to essentially poke the tumor cells and then understand what they can reveal about themselves if you poke them, if you kind of perturb them, if you treat them with drugs. How do they change, right? How do they react to certain drugs or combinations? Do they die? Do they change morphology? Do they express different genes? So we also have a program to be able to establish cell line models, if you want, cell models of cancer, and then treat them with different drugs and then assess how they respond. And so that allows us to get to many, many more data points about patients, but in this kind of ex vivo setting. So we think of these cells as avatars of a patient's disease. And really, for us, it's the combination of all of this information that we're integrating, and we're hoping that eventually moving forward will help us tailor therapy in the most effective way. It's not just one direction, but really the combination of these different technologies. So I'm hoping that gives you a sense of the kind of research that we do, and and at for every one of those directions that I mentioned, there are some really unmet needs that AI, I think, is really prone to potentially addressing. The one challenge that I think is really most immediately needed, I think, especially when it comes to genomics, is our ability to read cancer genomes. When we read a cancer genome from beginning to end, we can find thousands of mutations. The reality now is that we can probably understand the function of a fraction of those mutations, maybe 5%, and that's probably to be generous. I would love to see an AI model that's able to essentially, from the mutation in the sequence, be able to tell you something about the function of this mutation. How is it disrupting the cells, right? And creating an advantage, for example, for this cell to be able to compete, more effectively compared to cells that don't have the mutation. I think there's so much work to be done in that space, and a technology that's exciting to me in terms of maybe going in that direction is AlphaFold, right? AlphaFold is able to essentially fold proteins from sequence, right? But it's really good at doing that, but it's actually not so good at assessing what a mutation in that sequence would do to be able to change the function of a protein, change the folding, and maybe create a new function. And I think there's a lot of work to be done in that space to essentially be able to use protein folding, tools using AI to be able to assess what these mutations are doing that we see in so many patients. Maybe I'll stop here and get feedback from you guys about, feasibility of this kind of work.
No, it seems to me
very... Not just it's also germline. I think people sequence the germline, of many patients with different disease. Likewise, there you have variation. It's not somatic mutations, it's variation. But, we understand so little about these variations. We just don't understand what these variations do. Do they impact, biology? At what level? What's their function? There has to be a better way by which we can maybe use the UK Biobank, where you have genotype and, deep phenotypes for, thousands and hundreds of thousands of people, where we can do this mapping between genotype and phenotype more effectively.
So, Olivier, since the two teams requested me to respond to, I think that what the challenge that you put forward is a very exciting one and a true big challenge for machine learning. The opportunity, though, nowadays is exactly in creating this, you are mentioning the phenotype, genotype, and even connecting one powerful data set like the one you are building with a variety of clinical data sets that may be collected elsewhere. So I think one powerful idea that on top of what you mentioned, which is really all these sequence-to-sequence models and so on, is the ability to use large language models to enable us to really translate between these different domains and harmonize more diverse data sets that may tell different aspects of the functionality of these cells. So I think that's one of the opportunities. Another opportunity is I still, even though the world has seen a lot of work in what we call self-supervised models, I think more of it would be needed and brighter ideas would be needed for a problem like the one you mentioned. So in self-supervised learning, we are not really having labels all the time, but rather we are predicting all sorts of functionalities or things of interest. So I think in a high-dimensional and rich data like the one you mentioned, using biological knowledge potentially to create tasks. This is something we, the machine learners, don't like to do. We often create stupid tasks to do self-supervision. But I think the opportunity would be to combine biological knowledge, clinical knowledge, and create relationships between these high-dimensional data sets and the clinical data sets to really understand the role of these diverse mutations in creating a particular expression or a particular phenotype or a particular response. So I hope that large language models can improve both data harmonization to be able to have more clinical data that expresses different things and may be related to related or different mutations, number one. And number two, maybe improve the understanding and the relationship between these mutations through self-supervised learning that's more biologically informed. This would be two ideas that I immediately see as opportunities on this very challenging problem that you mentioned.
I think that makes a lot of sense to me. I mean, I think that you can think of this problem in multiple layers, right? So the problem I was thinking about is initially as I described it was largely a protein folding problem where right now AlphaFold is good at folding a protein from germline sequence if you want. But if you introduce a variation, I don't think it really knows what to do with this variation. It's not going to modify the folding based on that variation. It's not, as far as I know, capable of doing that, as of yet. And that might change tomorrow, but right now it's not capable of doing that. But I think to your point, I think that this should not be seen in isolation, right? Because obviously this, new fold, a new function is going to have a consequence in terms of the rest of what's happening within the cells. The transcriptome of, the cells is going to change, right, as a result, so you can really think of it as, multiple layers, which in theory, you can measure, and we may actually have enough data to be able to, combine all those different layers, right?
And even over time, and even potentially over time. So there may be different snapshots at different moments in time that now can be puzzled together.
I'd like to, to sort of maybe provide a follow-up challenge if you want, because I think once we've in theory been able to fold these proteins that have mutations that activate, any function within those proteins, then the next challenge is what to do with that information, how to block these proteins, right? And, for us, we're thinking about precision medicine, about, the future, and how it's going to be done. And I strongly believe that, in 50 years from now, we're not going to treat patients with an existing drug. For every cancer patient, we're going to sequence the genome. We're going to fold the proteins, with mutations. And then we'll actually create drugs for each individual patient. We'll actually create a new drug for your cancer, not for, the average cancer that lots of patients may have. But in fact, we're going to create drugs for your cancer. And so what it means that we're going to have to use, probably some AI type of modeling of, maybe the interaction between molecules and drugs and the protein sequence. and essentially create a new molecule from scratch and make sure that it's synthesizable, make sure that it's not toxic in people. There's all kinds of AI challenges that in theory you would want to, potentially address.
Definitely. And I kind of feel, Olivier, there are two parts. One is the understanding of cancer, the understanding of how to treat cancer, how cancer evolves, which is, I think, can use AI and these very diverse, potentially collected data sets from different institutions. And then there is the clinical day-to-day, which in many countries may not involve this wealth of information. And this is another place where I think it will be very interesting. Out of these complex data sets we have, how can we distill the minimum relevant information that we can give to a clinician in a country that's maybe less fortunate, where, unlike in your institution, maybe they don't have the good fortune to have everything. I think I need to stop.
Yes.
Makes sense.
Thank you, Professor van Schaar and Professor van Element. I would also advise that we take this into the discussion further because we still have a little bit of time at the end too. Moving on, we are honored to have Professor Han with us from KU Leuven. Would you be able to tell us about yourself in 3 minutes and share the medical challenge you have for us, the machine learning world?
Okay, thank you. I think I can incorporate the things that have already been discussed also. So my main line of work is breast cancer treatment, and it has a lot of similarities to prostate cancer treatment that Professor Oldenburg has already told us the challenges. And the bulk of the day is actually about making predictions, which we are very bad at as humans. So the healthy woman that maybe has family members with breast cancer, they want to know how much is their risk for developing breast cancer in the future, how should their follow-up be organized, and is their risk high enough to think about prophylactic surgery, which is can be very impactful on their life. And then the second part is the women that are already going through breast cancer treatment. Actually, the majority is cured after their local treatment, which means surgery and maybe radiotherapy. The big question is there one cell that escaped, which will cause a relapse in the future? And we don't know. We need to try to make that prediction. And at the moment, a lot of women are undergoing adjuvant treatment with all of the side effects who don't need it, just to save maybe 5% of women that will relapse if you don't give the adjuvant treatment. So that is actually, a huge part of improvement that we could find. And the adjutorium calculator that has already been developed by the group of Professor van der Schaar is one tool that could help us. I'm thinking, yes, can genomic sequencing help us answer that question? That's maybe one part of the puzzle, the biological knowledge to know more, but that still doesn't tell us if the tumor has escaped already or not. So how do we do that? And also, how do we convince clinicians to use the tool? Because adjutorium has been developed for, I think, 2 years now, but it's still not really often used in daily practice. The information that is available is not always given to the patient, so they cannot really help decide their treatment. They just hear from the oncologist, okay, you need 5 years of anti-hormone treatment. You feel like you're 100 years old. Yeah, well, that's the price to pay. but maybe the patient has a role to decide also about their treatment and how they think about the predictions that we are making for them. And how do we incorporate all that is known already into the daily practice? I don't have an answer for that. Maybe Professor van der Schaar has a little bit more advice.
Thank you, Sileni. So first, the topic of breast cancer is especially important and interesting to me because my own mother died young of breast cancer, and my grandmother as well. So they both died very, very young. So I'm very interested in doing anything I can to empower clinicians like you, and I thank you for the work you do. So you said, so I'd like to kind of backtrack. You mentioned the work that we did on Ajutorium. What I think the reason this is not used is partially because it was developed by two machine learning researchers, me and my former student, now professor in Berkeley. Public Health England contributed the data, and a retired professor of oncology, Adrian Harris. So I think what we need to move towards is building these tools, empowering clinicians to build these tools. So where I went in my own lab is we did Ajutorium more as a proof of concept to show that something we believe quite powerful can be built that outperforms clinical solutions in practice. So we know NHS predict for breast cancer, we believe it's not ideal. We believe that much better performance can be achieved. We wanted to show as a proof of concept that machine learning can do better than NHS predict, which is based on regression models. But our focus was more to show what's possible and create and build tools that hopefully clinicians together with machine learners can build. And then we hope that the clinicians are the one that will take, if you like, this goal of bringing these tools to their community forward, because we as machine learners neither have the knowledge or the ability to do so. In terms of building, so in terms of tools, I would be keen to engage, and I think not only me, all machine learners that are interested to truly make a transformation in healthcare will be very keen to join forces to build tools that are useful in the area of risk prediction. That's the reason we build this very simple now to use tools such that hopefully data scientists working with clinicians can do them. But on the joint decision-making between clinicians and patients, I think a lot can be done there to really understand why this particular recommendation by the clinician or by the machine learning decision support tool has been made. We can identify which similar patients to the current patients have been found, and show to both the clinician as a debugging tool, such that the clinician has a way to debug this particular tool, but also as a shared decision-making with the patient. It could show very similar patients to the current one in the mind of the machine. And this could be informing also the decision between the patient and the clinician as well, and potentially identify alternative options and what happened to those patients. I think that this is very much possible with tools that we have that are making, that are enabling us to identify not only predictions for a particular patient, but also what happened to related patients, what would have happened under different types of interventions. This type of tools exist. I think what we need is uptake by the clinicians and vision of the clinician to build these tools. I think the technology exists, but how to make it, the machine learning technology exists, but how to make it useful, truly useful for patients and clinicians, that is something I think requires clinicians' vision.
Thank you, Professor Han and Professor van der Schaar. And Thank you, Professor Hahn. It touches on the most fundamental part of medicine. First rule, do not harm. When do we have to harm? Very amazing. Thank you.
Yeah.
Let's also move on to Dr. Crosby. We're all keen to hear about the strides being made in cancer research. Could you please share your research focus and your challenge?
Sure. Thank you very much, Tim and Nahala, for the invitation to be on the panel today. So I guess I'm something of an outlier on this panel in that I'm neither a clinician nor an active researcher myself. So I work for Cancer Research UK, recognising the international audience. I'll tell you that Cancer Research UK is a charity. We raise funds from the UK public to spend on cancer research across all fields, from very basic discovery biology through to applied health system facing science. My job is I'm the head of prevention and early detection research. So I think about end to end, from kind of molecules and technology innovation through clinical research to health systems research. How can we best use the money that we have available to support and nurture and stimulate science to accelerate early detection and prevention of cancer? So my background is I was as a clinical pharmacologist once upon a time. I did a lot of cell signaling research. I've worked in industry. I've worked for the public funding agency in the UK, the Medical Research Council, and have been at Cancer Research UK in this job for about 6 years now. My interests are very broad because the role demands breadth. So I think about biomarker discovery and validation. I think about technology innovation. I think about epidemiology and risk. I think about clinical research, trials, and health systems facing science and behavioral science. And really, there isn't a single one of those domains where machine learning will not have an application and an impact. But your challenge to me was to think of one particular challenge space that I'm interested in, and I can certainly do that. The curse of going last in a panel like this is that basically all the important things have been said, but not all of the important people have said them. So I'm going to repeat some of it. My significant area of interest at the moment is around risk and understanding who is at elevated or decreased risk of having cancer right now, or perhaps more importantly, of developing cancer in the future. And I'm particularly interested in the possibilities of a multimodal data integration driven holistic modeling of cancer risk. So if you imagine that across all the sort of different domains of research, if I were to try and predict who is at elevated risk of cancer, you would of course think about genomics, and we heard a panel talk about germline genomic risk of cancer. You would think about behaviors. You would think about smoking, of course, alcohol consumption, diet, exercise, sleep patterns. You would think perhaps about social factors that confer risk of cancer. Your socioeconomic status, your educational background, where you live, all changes your risk of having cancer or developing cancer. You would also think about phenotypic stuff, blood biomarkers. You would think about imaging. Now, individually, each one of those is highly amenable to machine learning approaches across big data sources to try and get a more nuanced view of risk. And if we take genomics as just one example, there are the few sort of low-hanging fruits of the highly penetrant risk variants, BRCA being one obvious example. But there's a constellation of minor variations conferring much smaller risks, that there could be really complex patterns of those that we could tease out with machine learning approaches. But that's just in one domain. Now then, if you think then about the enormity of data across all those different domains that I've talked about, suddenly the scale and the depth of data becomes colossal. And then the challenge of integrating those in a formalized, quantitative way, I think, absolutely necessitates advanced data analytics. So if we could get that right, then the kind of so what bit is, well, you could think about precision screening. You could think about targeting your screening and detection efforts to those who are elevated risk, where you are much more likely then to get benefit, much less likely to get harm, as we just touched on with the last speaker. And then there's also application in early symptomatic diagnosis, and the folks who walk into a GP with feelings of malaise or vague abdominal pain or things like this, which can be lengthy diagnostic journeys. If you understood risk, you could target your diagnostics there much more precisely. And then ultimately prevention, and in whom would you like to intervene if you had a preventive vaccine or other approaches or preventive drugs. So there you go. There's my pitch for Mihaela and colleagues to sort that out for me.
Well, David, the good part about, so you mentioned multimodal information and high diverse data sources, whether it's the biobanks that the UK have or United States or any of these highly resourced countries. I think the challenge is more in getting the data. I think what you are saying is identifying what is the minimum amount. So you see, people often think quite maybe simplistically about machine learning. They think, oh, this is about large amounts of data, partially because I think in the media, people talk about large amounts of data which they need to really build machine learning models. But the reality is, I always said the science in machine learning is in the science part, not in the data part. And even when you have this data, whether you have it big or small, I think the important part, and this is something that machine learning can do today, is what is the minimum amount of information that I need for a particular individual to make the right recommendation of precision. These tools exist today. Why they don't get used, I don't know. But the reality is that this is a problem that can be solved today. And I think I would completely agree with you, David, that this seems to me the most important and most powerful low-hanging fruit where machine learning can contribute, not to get more and more data, but rather to help us dissect what's the minimum amount of data that is needed for a particular decision, and what would be the cost to the patient or cost to the healthcare system, and to acquire more information, and how much this would improve our predictions, the certainty in our predictions, or the certainty in terms of which diagnosis to choose. So quite excited to hopefully do something there.
Yeah. I mean, I agree with that completely. And then in terms of informing decisions, also I suppose being able to quantify and express the uncertainty, and that which people aren't very good at and aren't very good at quantifying or receiving and understanding the information. And so giving people the relative probabilities of there being a cancer, or the relative probabilities and risks of going on and having the next diagnostic test, and how that's going to play out for you. And it's complex.
Thank you both, Professor van der Schaar and Dr. Crosby. I saw that Professor Oldenburg has his hand raised.
Yeah, thank you. These were excellent presentations and discussions. I think what David said, the risk prediction is so important, and it is. I would like to highlight. I think Mihaela mentioned that it's not a cross-sectional status. It's usually developing over time. So there's a dynamic development, and I think somebody called Heraclit said, "Padarai, everything is moving, everything is flowing." And for prostate cancer, and I imagine for breast cancer, this is especially true, because the risk is very dependent on the life expectancy of a given individual and the comorbidities. And the life expectancy usually is reduced by time, and the comorbidities are rising, and this should ideally be incorporated. And like Selene Hahn mentioned, for breast cancer and prostate cancer, there are a lot of similarities, and I think the biggest one would be that is the dilemma of overdiagnosis and overtreatment. There are many patients for breast cancer, at least, who have just a localized tumor. The tumor might harm the female or might not, but if you're in doubt, take it out. This is more or less what is done, I think. And then you have the role of adjuvant treatment, and it's very similar for prostate cancer. We have many patients now not undergoing any treatment, just having active surveillance because you think you might harm the patient by treating it. But of course, if you find a cancer which you do not treat, you shouldn't find it, because it's just another worry the patient will have. And it is quite demanding for the public healthcare system, which is the standard care in Norway, to really focus on these patients who need treatment, and then have the MRI capacities, for example, for bladder cancer. It's a lot of thoughts in my head. But one comment to Michaela, when she said it is not to get more and more data, it's more about getting the right data, the important data. But how do you get that? Usually, I think you have to look at all the data, and then you see what is the driver, what are the passengers, and then you deselect the passengers. But probably you will have to look into the whole busload of information and then select the most important seats. That would be, but I would be curious how.
No, exactly, and exactly as you said. So that's the reason I said one thing is about, and I was discussing this with Olivier, one thing is about understanding. So the understanding phase, maybe to understand disease, you need more factors. Then when you are building something for clinical practice, like you say, ideally I have all the information I need, but the focus will be not to build predictors which contain all this huge amount of information, but rather the minimum amount that is needed to make the right forecast or the right decision. So yes, you are correct. I start with a lot of information, but then I try to discover what's the minimum amount for the person in front of you. And hence it can help with identifying tests that can be made for this individual. What are the right tests? Something that I'm quite fascinated about, and I think some of you mentioned multimodality. Well, when should a woman, for instance, if it is to talk about breast cancer, should do an MRI? When should she do just a mammogram? So even the accuracy of, so it's not only information, but potentially is also the accuracy of that information, or the informational content that you can get from a particular test.
Sorry,
so maybe modality or yeah.
Thank you so much, both. And because this is already about data, we also had one question from the participants on potential bias. So the question was, AI models can be biased, and how would clinicians avoid or realize such potential biases by AI models?
Well, so first, I'd like to start by saying that of course, it depends on the data that you are collected. If we are talking about data that it is used for screening, then the machine learning models that we have, they need to be tested correctly, and they need to be tested in subgroups, not only as the population level. If it is to talk about the data that we collect, unfortunately, the data that we may collect, especially in an electronic health record, may be inherently biased to people who are showing up or who are having a particular characteristic that enables them to be in that particular data set. So one needs for sure to take this into consideration, but machine learning models can help deal with the biasing data, augmenting data sets, and improving the quality of the data prior to doing any machine learning models on them. So improving fairness and debiasing can be possible. But finally, since one of my collaborators that's working with me on this is on the call, Alex Gimson, I also want to say that together we had a few sessions ago, a session where we discussed that maybe clinicians could be biased as well. And I'm not talking here about negative biases that they discriminate, but rather because they see a certain type of patient. Maybe they are very used to treating that patient, and they are less used to treating a patient that would be quite different. So even clinicians may have indirect and inherent biases based on the population they see, based on the education they have. So I'd say this is all about the data that a human clinician or a machine learning method ingests. So what we need to make sure is that we are debiasing correctly and we are using this information correctly if it's about prediction. But if it's about treatment effect estimation and identifying which treatments work best, well, the data is inherently biased because clinicians have their own knowledge and expertise in determining who they should treat and who they should not. So this is why causality, causal effect inference are so important areas in machine learning, since this is not bias, but rather expertise that's exercised and needs to be carefully accounted for in machine learning. And that's a hard area of machine learning.
Thank you.
Yes, and thank you everyone. And unfortunately, the time never stops. Let's see, we have about 5 minutes left. So I would maybe ask every panelist, because thank you again for coming. You all have very busy schedules. Every panelist to summarize your final thoughts, and if you have a key message for the audience, to share that as well. Professor Elemento, I saw you had your hand raised. Maybe we can go with you first.
That sounds good. I was going to ask a question about validation of medical AI models, because I think that, we're talking about a lot of different AI application in a medical setting, and validation is really critical. And I think the standards and the processes for validation of medical AI models, I think, in my view, are not very well established at this stage, and the gold standard data sets are not necessarily also very good. I mean, they probably have the same biases that you have, training data sets. So the field maybe needs to do a bit of reflection on, validation of medical AI. Like, what does it mean? What are what's the level of validation that you need to achieve? Do we have the right data sets for this kind of assessment? Are they biased as and maybe we should create new data sets moving forward that would be gold standard. So maybe that will be
Olivier, it's fantastic. Sorry, I know I'm not allowed Tim to respond, but I'm too excited about this challenge. So Olivier, I completely agree with you. And actually, very recent research in our own lab is trying to address exactly that. How do we build data sets that are very different than the training set and maybe more similar to the place we are going to deploy them? And how do we keep, as the population potentially is changing or additional information is added, how to do that? And we are combining some synthetic data with real data, as well as modulating this data based on information about the target deployment data set. So look forward for a conversation on that. Thank you for this challenge.
Thank you. And also thank you for being excited, Mihaela. Professor Oldenburg, I wanted to go to you because you're already stretching this meeting, as I know. So would you be able to summarize and have a final key message for us, the audience?
It's a hard task. I think it was a really excellent discussion. I enjoyed it. I think what I see as the biggest challenge is the limitation of data, of highly granular data. And when I mentioned the phase 3 trials, usually you have groups compared. You don't have the individual patient data. And I think that would be used by an AI ideally. But again, what is selected for clinical studies is a lot, but I think it's not nearly sufficient to find out the driving forces. And probably this is something UK research can contribute to, and clinicians have to be quite active, I think, to open their data. That would be my take-home message.
Thank you a lot. Professor Han, could you also summarize and do you have a final key message?
I think I am stimulated by the challenge that Professor van der Schaar gave me, which is how can a clinician develop a vision to incorporate the information that we have from machine learning into the clinical world, and how can you translate that so that the patient understands this information and can use it for their decision making. So we will need to brainstorm about that to see how we can go further. Thank you for stimulating me.
Thank you. Dr. Crosby.
Thank you. So I note that even though I complained about going last previously, you've still made me go last. I would like to build on Olivier's point. I think that validation question is absolutely crucial. So the question, I think, when we are looking to validate and then really to translate any kind of machine learning algorithms or models into practice, the question that we don't fully know how to answer is what does good look like, and what is the acceptable threshold of a model's performance to say, yeah, that's good enough, we should implement that should be used. And I think, bearing in mind the audience that we have here today, I think clinician input into that is going to be absolutely crucial. It's for you to tell the machine learning research community where are the areas where you require input, and what are the performance characteristics that you want enabled to be confident that you would want to use that model in informing your clinical decision making. And I think we need, as a system, to get much more tight and kind of robust around saying up front, like, where the bar is for machine learning models intended to support clinical decision making. What are the performance characteristics that we need to, as we do for diagnostic tests, for in vitro diagnostics for drugs, we know what the performance characteristics are that we're going to measure, and we know where the bar is. What have they got to hit in order to be usable? The same should be true for these emerging models.
Thank you so much. And also thank you again for joining us. I think your input was very vital and also really inspiring. So thank you again.
So coming to the end of this great session, again, also thank you from my side. We just want to point you towards the direction of our next session, which will be on ML for multi-omics. So this will be a tad more technical, but hopefully as interesting as this one. Additionally, we have one more thing to share. The Cambridge Centre for AI and Medicine will run 2 inspiring summer schools this year. And for the first time, we actually have a summer school designed specifically for clinicians and medical students without much prior experience in ML. You will have expert clinicians, machine learners, and statisticians who will teach you everything you need to know to get started. Hands-on sessions won't fall short either. Places in these schools are limited, so be sure to register soon. We even have some early bird discounts available. And as always, please spread the word about the summer school and about these sessions. And we really hope to see you again soon. Thank you again.